Okay, well, welcome to today's webinar. As you know, I'm excited to be bringing in and pushing the envelope on what more we can do to understand cardiovascular health. And when it comes to artery disease, it's a biology disease. There's a lot of biology that happens to the artery wall, and we're going to talk about this today. And when we look at artery disease, inside the artery wall, it's all skin, just like the skin on our face. We look at inflammatory markers at the clinic. We look at particle sizes that are slithering through, and then we want to understand the infection response as it relates to artery disease. But I brought on some experts here to talk about that part of it. And I got Rhonda and Aparna from Provenio that are going to talk about this new test that we can do that will be life-saving. And I'm going to turn over that conversation over to them so that they can understand what you can do and an important test to understand cardiovascular disease risk. So welcome, Rhonda. I know you're going to be talking about the testing and all that stuff today. So I know you got a lot of things to go through. But again, before we get started, I always like to talk about the artery. It's a muscle. It's not a pipe. And any doctor, even if they're a smart cardiologist, they say your pipes are clean. That's not what you should be saying, and tell them Diamond told you that, because there's a lot of biology that happens to the lining of the artery wall. As we look at the anatomy of the artery wall, you can feel it expand and contract in different areas. So inside the area lining of the artery wall, it's all skin, just like the skin on my face. What is injuring it? What can sliver through, and then the infection response. So we got Rhonda, who's the CEO and Chief Translational Officer of Provenio. They're a lab in the US, and we're excited to hear them talk when it comes to cardiovascular health and artery disease. So Rhonda, I'll leave you the floor.
Diamond, thank you so much. And it's an honor to be here presenting some really exciting work that we're doing in partnering with HeartFit. So Provenio's disrupting cardiac diagnostics with AI-driven early detection and risk stratification. And if we just look at cardiovascular disease, in Canada, it's a leading cause of death. 80% is preventable, but many patients go undiagnosed or misdiagnosed. And challenges that contribute to that involve, one, inaccessibility of current cardiac tests like stress treadmills, echoes, imaging. They're not very accessible if you compare them to a highly accurate, accessible blood test. Oftentimes, they're inconclusive or inaccurate. And also, there's a shortage of Canadian cardiologists, much like in the US, where you have to get to the cardiologist before you get these tests prescribed and conducted. So that's the value.
Yeah, Rhonda, this is exactly the point that I try to share with, and this is what I talk about in my new book, and Death of the Stress Test, is that the stress test is not the right test to do to understand cardiovascular disease risk, because it misses a lot of testing that goes wrong. And when we look at all the testing that's available, cardiologists weren't trained in this arena. They know that if there's a problem with it, we can then go onwards to do further investigation. Like if it's a structural problem, or if it's an electrical problem, we can do an ablation, or if it's a plumbing problem and if it's an advanced issue, then we could bypass or stent. That's where the training is. And cardiologists are trained to not tolerate ischemia. That's one thing, but they're also trained to they're not preventative. They don't focus. None of their school talks about prevention.
I agree more, and we need to be more preventative. So Provenio partnered with Massachusetts General Hospital and world-renowned expert Dr. James Januzzi to really develop tests that are accessible, accurate, affordable, and actionable. And what's different about what we're doing is we used AI to select multiple proteins, optionally clinical parameters, and put them all together in weighted algorithms. And that's really allowed us to develop these blood tests that are highly accurate and accessible. We have 2 blood tests that we're partnering with HeartFit to offer. And the first one is a risk test, and it's called Heart CVE, standing for cardiovascular events. And it's looking at a patient's 1-year risk of heart attack, stroke, or cardiovascular death. And who wouldn't want to know that? We actually have data going out upwards of 5 years. but we need you to know if inside of a year you have this risk. Very much complementing this risk test is a diagnostic test, heart CADhs. That stands for coronary artery disease or heart disease. And it's telling if you have obstruction in your heart vessels and an imminent risk of a heart attack. So together, these are very good baseline tests. They're very helpful on a variety of patients, those with a history of cardiac disease or risk factors like high cholesterol, high blood pressure, diabetes, kidney disease, obesity, smokers or smoking history, peripheral artery disease, family history. So a broad range of patients. If Diamond does not have any comments, I'll go on to talk more about the first test.
Well, I can comment all day long about different things for sure, but I just want to bring up, if you can go back on that slide there for a moment, Rhonda, when you look at the two different tests, understand this is very important for our listeners, is that the majority of heart attacks actually occur with blockages that are less than 50%. So what I mean by that is inside the artery wall, if we look at a blockage that is under 50%, that's a pimple. Like artery disease builds up like a pimple on our face, just like just like a pimple on our face. Imagine that pimple growing inside the lining of the artery wall. If that pimple pops, that's a heart attack. And I just wanted to talk about the difference between a plaque rupture and ischemia or obstruction. So that's very important, two distinctions to go back and understand on, is that when we're looking at obstruction, that's more, okay, what do we do to improve that blood flow? If you're looking at plaque rupture risk, you can have a plaque rupture risk that is just having like construction on the side of the road. It's only like 5 or 0% blockage, but it's building up like a pimple on the outside of the wall, and that can still rupture. So I just wanted to talk about those two differences quickly.
That's an excellent analogy, Diamond. So heart CVE is looking at that pimple building up and maybe rupturing, and CADhs is looking at the obstruction in that pipe.
But it's not
So
a pipe.
heart C, what was that?
The artery is not a pipe, it's a muscle.
Oh, sorry, it's a muscle. So heart CVE is looking at that 1 year risk of heart attack, stroke, or cardiovascular death. And some items that Diamond had mentioned, we had the machine learning select the proteins that are in this test. And one of them is NT-proBNP, which is a protein known to measure the stress on your heart. Kidney injury molecule really evaluates the stress on your kidneys, which also affect your heart and vice versa. And then osteopontin and TIMP1 deal with plaque and plaque rupture potential and vascular inflammation. And that's kind of that pimple that's growing and may be vulnerable to breaking off and causing a stroke or heart attack. So again, it was the machine learning that selected these and put them together in a weighted algorithm. And when your blood is tested at a heart fit clinic or collected, it's sent to our lab where on platforms it's measured, and then those protein values are uploaded to a secure Azure Microsoft cloud where the algorithm is applied, scoring and report generations done. And these reports are very understandable and actionable for not only physicians, but also for patients. The score is divided into 3 risk levels: green for low, yellow for moderate, red for high. Very easy to understand. We also, on the protein values, give serial measurements, and we also give serial risk scores. So this is an actual patient that in January 2021 had a 9. The doctor intervened medically. 9 months later, went down to an 8. A year later, went to 7. Still in that high risk category, but moving in the right direction. And this particular patient was recently tested and is down to 5, which is in the moderate risk category. So again, this test allows clinicians to select correct medications based on risk levels and the individual protein values. And if any of you have been tested for either heart test, you'll see a report very similar to this, and your clinician will be able to easily explain it. So if we just look at where is this in the medical community, we've had 15 peer-reviewed publications and presentations on this test at very well regarded manuscripts and journals, and also at American College of Cardiology, American Diabetes Association, American Heart Association. So all the leading medical shows have had this data presented. And when you look at the accuracy compared to other tests, we try to say it complements other tests. But if you look at hazard ratios, the higher the hazard ratio, the more accurate. If you compare it to other single proteins like little LP little a, your lipids, which more than half the people who have a heart attack have normal lipids, CRP, troponin, those are all less than 2. Even your coronary artery calcium scores are less than 5. So you can see that these tests are more accurate and complement other tests that are out in the marketplace. Overall, the heart CVE had an accuracy of 86%. Diamond, if you have any comments on heart CVE, I'll pause. Otherwise, we can go to the second test.
Yeah, I just want to go back on that other one there quick, Rhonda, just for that side of things, is that this is really, I love this slide, by the way. And when we talk about this, a lot of, I think that you hear a lot of people talking about get a calcium score and see what the calcium is. And my concern with that is that it doesn't look for non-calcified lesions. And I think that's very important to understand, is that think about, again, I'm going to go back to our analogy. So inside the artery wall is all, it's all skin. It's inflammation that we're trying to look at. And when that goes through the particle sizing, that's why lipid panels, like if you go look at the studies, get with the guidelines, the majority of people that have heart attacks and strokes have normal cholesterol profiles. So it's important to look at particle sizing. But then the last part is the immune response or the infection response. And this is why this part of the testing is looking at that part of it, because when you're not able to look at non-calcified lesions, so we've seen people who have had heart attacks with very low or to normal calcium scoring because the plaque hasn't calcified. And when it's healed itself, that's important to understand. But this is then, people then lead, okay, well, it's high or it's a number or whatever it is. I say, who cares? Because it doesn't tell us the non-calcified lesions. So then people go and say, okay, well, I got to talk to a cardiologist. And remember, cardiologists love you, but they're not in the prevention game. That's not their game. Their schooling, if you look at how they go to school and how they're trained, it's all based on emergency heart management. And it's so important to have a cardiologist on your side when you're having advanced problems, because a lot of people say, okay, well, I need a cardiologist. I need a cardiologist. And yes, that's true if you have advanced concerns. But their job, their prevention model is just take a statin, and it goes beyond taking a statin. And so this is why getting a calcium score or even leading towards CT angiograms, you're asking for a lot of radiation where it could be unnecessary, and that's not the path that we want to go down.
Absolutely. Thank you. So heart CVE, we just covered, it's your risk test. And the next test we have is heart CAD. Again, that stands for coronary artery disease or heart disease. And it diagnoses whether you have obstruction. And it really complements the last test. Again, we used AI to select the proteins and clinical parameters. And this time it selected high sensitivity troponin, which maybe many of you have heard of troponin. It's really good at ruling out heart attacks or ruling in heart attacks in the emergency room. It's not very good at saying, do you have obstruction? Only about 60% accurate to say, are your arteries obstructed? But combining that again with kidney injury molecule, that kidney marker that reflects heart problems with adiponectin, which looks at fatty acid and glucose metabolism. Putting those three proteins together with a patient's age, sex, and history of heart intervention gives us significant accuracy. The report is very similar to heart CVE in that we have 3 risk levels this time on a 5-point score: lower, moderate, and high, green, yellow, and red. And we give the serial monitoring protein values as well as the scores. And HeartFit has a very sophisticated protocol for treating you based on your risk levels and protein values. Heart CADhs has at Mass General an accuracy of 85%. When externally validated on an entirely different cohort of patients, 86%, and looking at women just specifically, 85%. If you have a score of 1, you have an 89% or low likelihood of having obstruction, 97% if you have a score of 5 for having a high likelihood of obstruction. And we have 8 peer-reviewed publications and presentations, again, very well-respected journals and cardiology meetings. And I'll pause there before I share some practice-changing clinician testimonials to see if Diamond has any comments.
No, I think I always like to go back and see the data, because I think this is important to understand, is that just going back to the other slide is that, no, sorry, just the next one here. Just at the meetings where you bring up the peer-reviewed presentations and the peer-reviewed publications, this is all new. Like, I just want to keep this important, is that this is all new when it comes to asking a cardiologist about this test. This is not something that's regularly covered in our healthcare system in Canada here. So this is why we have to go above and beyond what's get done in conventional testing, so that we can go and find out what cardiovascular disease risk, because there's a lot of biology that happens to the lining of the artery wall. And now more and more physicians are being educated as to the artery musculature of the artery wall and the biology of the artery wall, because they don't learn this, going through med school. So this is important stuff to understand.
Absolutely. So just in all, we have a variety of physicians and clinics using this. We're so pleased that HeartFit is introducing it in Canada, but physicians that have used it and clinicians talk about it alerting them to the urgent need for intervention and saving lives, educating patients. If you think about a treadmill, an echo, an image, it's really hard to understand what those mean. But with the scoring system and the green, yellow, and red, I think it's very important that we as patients can understand what our testing is doing, as well as the clinicians. And again, it's educating patients, taking appropriate medical intervention with accessible, accurate blood test. And with that, I'll turn it over to Diamond to conclude and to have any question and answer. Thank you so much for this opportunity.
Yeah, thank you. I just wanted to go through this really quickly. If we can go through, Rhonda, or maybe Aparna can help us evaluate the scores a little bit, and just go to the details as what this test means, because we have started to do this test for our patients in our clinic. And when we start to look at the concerns that happens from it, it gives us some more information while looking at the other biology markers that we do at the clinic to understand what we can do to help you with your heart health on that side of things. So I know these numbers are pretty high when it comes to looking at the CVE report, but in my opinion, I think anything above a 0 is not good. And I want to just comment on that, because then it's just starting to show that things are starting to go off on the right thing, on the wrong path, sorry. And so maybe if you can just comment on the score and the scoring profiles as to where we're at with that. So.
Sure, I'll start with that, and Aparna, please feel free to add. So on this patient, it's obvious they are in the red zone and something needs to be done. So the physicians looked at not only the risk score, but then looked at the protein values, and the NT-proBNP, which is associated with heart stress, was very high. So they prescribed something to take the stress off the heart, like an ACE inhibitor or an ARB, an angiotensin receptor blocker or a beta blocker. These names may sound familiar to you, and they all kind of take the stress off the heart. Osteopontin and TIMP1, since they deal with plaque and plaque rupture, like that pimple ready to rupture, the clinicians consider educating the patient on maybe going on a statin or up titrating the statin, and also anti-inflammatory medications. And then again, the kidney injury molecule that deals with the cardiorenal or the heart and kidneys. And if those are elevated, and especially if you're a diabetic or you may have excess weight, they might prescribe those newer drugs, the SGLT2 inhibitors or the GLP-1 agonist, or some other drugs that help with the kidneys and with cardiovascular risk. Parna, you're on mute, but I know you do a lot of interpretation, so please feel free to add to that.
I think you nailed it, Rhonda. 9 is high. We are looking for, maybe Rhonda, you can talk about 0 to 1. We really don't see a whole lot of difference, but yes, the goal is to get it as low as possible, and the treatment helps. Our test is so dynamic that within a span of about 2 to 3 months, if the treatment is correct and if the treatment is changed, the lifestyle factors have changed, the score does come down. So this patient perhaps had a lot of factors, and with treatment, he's going in the right direction. So yeah, NT-proBNP, it measures the stress on your heart. How hard is your heart working right now? And that's what it measures. Osteopontin measures your heart plaque. TIMP1 is interesting because it measures ruptured plaque. And that's really important. That's what Diamond was talking about, that popping of the pimple. TIMP1, that rupture is what causes an MI or a stroke. So that's really important. And kidney injury molecule is a very sensitive molecule that measures cardiorenal injury. So we're giving all of these values, and these values help to personalize the treatment for the doctor.
Absolutely. So they cover the heart stress, they cover that plaque, potential for rupture, your kidneys, and the vascular inflammation. So it's extremely comprehensive. And as Diamond said, you want it 0. You want to get it as low as possible. So we've even had patients who are 2 or 3, but the physicians with the patients are intervening and trying to get it as low as possible, because we all need to have healthy hearts. It's the leading cause of death.
And this is why it's important, when you look at it from that perspective, is that artery disease is biology. It's a biological disease. And so this is why you have to look at biology markers. And, our clinic talks about all the time, cholesterol does not cause heart disease. Like, it's not cholesterol that accumulates to this pipe and you have a last cheeseburger and fries and you end up with a heart attack. It does not happen that way. And so this is why it's important when you're looking at these biology markers, it's giving us more information. And so when you come to the HeartFit Clinic, as most of you have, we're looking at inflammatory markers, we're looking at particle sizing, we're looking at the immune response, we're looking at markers like this, and then we're physically looking at our testings that we do with our heart scanners and looking at the artery function and stiffness. Those are all important things. And then looking at the Y side of things, getting into nutrition imbalances and gut inflammations and and all that side of things that we get into the HeartFit clinic. But this is just another powerful test that we've added to our arsenal so that we can get understanding what we should do about cardiovascular health and what we can do to improve. Because the testing is getting better. And this is why at the HeartFit clinic, we want to be right at the leading cutting edge of it, especially in Canada here.
I see a few comments in the chat box.
Yeah, so what I'll welcome is that if you have any questions, you're more than welcome to take yourself off of mute and ask questions, or you can put questions in the chat box and I'll moderate them as they come in through. So I guess, can non-fatty liver disease be a factor in heart function and iron overload? My answer to that is absolutely yes. That is a key factor. But this is why it's important to look at other markers to see where you are in spite of. I don't know, Rhonda or Aparna, if you wanted to comment on any of that too.
We would absolutely agree with you. It's all so interconnected, and we talked a lot about the kidney and heart, but the liver's very much a part of that puzzle.
Hi there. I'm wondering if you can hear me. I have a question.
Yes, we can.
I'm recently a diabetic type 2 since, say, last November, been on metformin. I did go to the HeartFit clinic here in Burnaby, and just to get their overall view of what they offer versus just your regular medicine doctors. I am going in for, saw a cardiologist last November and finally getting in and getting an echocardiogram this weekend, just as a test and follow-up. What will that provide me versus, say, these blood tests, these high advanced blood tests you guys are promoting?
Yeah, so I'm going to comment on that and tell you where the role is on different testing that gets done. So let's start off and I'm going to take a moment to educate you a little bit about heart disease. So when we talk about heart disease, it's going to be one of three pillars. So think about three different pillars. You've got the electrical pillar, which is the electrocardiogram that can get done. So that's the brain talking to the heart. Then you have the pillar of the structure of the heart. And that's looking at the valves and how the chambers look, and we're concerned about heart failure there. So with the electrocardiogram or the electricity part of the heart, we're concerned about atrial fibrillation, or maybe you need an ablation or a pacemaker or something to that effect. With the structure of the heart, maybe you need a valve repair, or we got to treat heart failure. But when it comes to plumbing, we kind of fail on that side of things. And that's where a stress test, and that's where my book is called Death of the Stress Test. It sounds like I really hate stress tests. I love them. I just don't think we should put all our eggs in that one basket, because it's only looking for advanced stages of disease. So the test that you're getting offered at there is an echocardiogram, which is an ultrasound of the heart, which is looking more at the structure of the heart. As a diabetic, we don't get too concerned about the structure of the heart, other than maybe the left side of the heart. But where you want to really focus your attention is on the plumbing. Because as a diabetic, but arteries aren't a pipe, remember, they're a muscle. As a diabetic, we're concerned about the inflammatory response to your artery wall. And a test like this and the test that we do at the clinic will give you some important markers. This is a newly diagnosed diabetic, so that we can make sure we do not end up with coronary artery disease, which is a plumbing or a blockage, or of course a heart attack. And so again, as I started off with this conversation earlier in the earlier slides, there's a difference between being ischemic, which is lacking blood flow, and the risk of a plaque rupture. Those are two different things. And cardiologists are trained to look for ischemia, not plaque rupture. So to answer your question in a quick way, the echocardiogram is looking at the structure of the heart, and continue with that. That's fine. But the HeartFit clinic will help you with the plumbing, but arteries aren't a pipe. Remember, they're a muscle. And this is why we look at the biology of the artery wall. Hopefully that answers your question.
Yeah, no, thanks for the clarity.
I think there was a couple other questions there. Go ahead.
Diamond, it's Joanne, one of your first ever
ever patients. Remember me?
Absolutely, Joanna. I never forget anybody. So absolutely, and especially my earlier people that have been with us for such a long time. So
Oh my God, guys, like I'm so excited to see you again. Like it's amazing. So, but I don't have, well, I'm pretty sure I don't have heart disease. But so my question to you is, I still have my myocardial bridge, right? So
yeah, I remember. Yeah.
that's over on the left and it restricts it at rest at 50%. So, I can exercise, but not again to what I ever used to be. What that happened to me when I was 42 and I am going to be 58.
My
So,
goodness, it's been that long.
well, that's what I'm saying. That
Yeah.
you were the first one to guess, right?
Yeah.
Um, but I'm finally off all my heart meds, just to let you know.
Mhm.
I went off by Stolic last year. So I have
Mhm.
been on that medication since, well, I got it before I even came to Canada. Because remember, I flew to the US and got it there, right?
Mhm.
So my question is for you, with these, I would love to do these blood markers because it runs in my history. My father just passed away 2 years ago from heart
Sorry to
disease,
hear.
and my mom has it, right? But I have low blood pressure, all that stuff. I don't have high blood pressure or anything else. My last MRI, Dr. Howard said that it was really good. The last one I had was I was 54. So my question is, and if I do all this blood work and everything, as you well know, in Canada, what I don't like about Canadian cardiologists is, do they work better with you now? Do they like, I mean, that was the problem I always had. Even when I went to the US and got my test there and brought it back to Canada, you know what I'm saying, Diamond? Like, so if I do this, and let's say I got a score of 1. I go back to Dr. Howarth, where he thinks I have, for getting close to 60,
Mhm.
and my cholesterol levels, all that stuff, like all that stuff is really good, right? I lost 40 pounds, by the way. So
Congratulations.
yeah, well, menopause kind of put a little kink in that for most women with menopause. That's what happens, right? So that's my question. If I do all these testing, will they acknowledge this to help me prevent anything as I go into my 60s and 70s?
I think I think it's very important to understand, like, and so to answer your question, John, I've I mean, I think for those of you who don't know, I'm the president. I was the past president of the Canadian Association of Cardiovascular Prevention and Rehab. Um, I was I'm still heavily involved in the Canadian Cardiovascular Society in the rehab aspect of things, and I'm involved with conferences and education that the cardiologists are supposed to go to. And I've kind of given up on, as you probably remember, I've given up on trying to please cardiologists. I'm not here as a pleaser of cardiologists. And uh, and I mean, I go skiing with them all the time, and I got invited to go to Whistler with a handful of them. But it's different seeing them on a personal level versus a professional level. And the way I see it is that um, they're there to make sure that you don't have advanced problems. And if you don't have advanced problems, then just leave me alone. Go to the heart fit clinic and make sure you don't. So they're not there to prevent heart disease. They're there, I mean, they're doing their best within a specific box of guidelines. But
Yeah.
coming to the heart fit clinic, we're looking outside that box and trying to go more in depth as to what more you can do. And this is why we do what we do, because that's the purpose of the book. Is, it's coming out here. I'm just going through some editing, so that's why it's fresh in my head. But the idea is that it's not cholesterol that causes heart disease. It's not, stress tests and calcium scores and angiograms are not the way to diagnose disease. It's important if you're having a heart attack to do those things. But this is why we're going above and beyond. And not everybody cardiologists are trained in that. And so to answer that question, I don't know. And if a cardiologist is a lot more well-versed, you can see how this tests like this are being presented at the American Heart Association and big conferences. But I'm not there to be responsible for their education. I'm here to educate you, the end user, to be able to understand this, because at the end of the day, it is a private clinic. You have to pay for these services. And unfortunately, it's not free for everybody, and so it's not covered. And so in Canada, we have to go above and beyond if you're trying to prevent or even reverse cardiovascular disease. Hopefully that answered your question, Joanne.
Yes and no. Like because I've already been, like, you were a miracle worker for me, right? But my issue is my husband, which you have seen as well.
Of course, yeah.
So he is scheduled next June for a few tests, and I don't agree. You've done multiple stress tests on him, and so I don't know what's going on with Mike, but Mike's 62 years old now. So, and I was telling Mike, this is why I'm on here tonight, because he's in BC working diamond, so he's there. But yeah, I'm just wondering whether or not, I guess, what does your clinic do now? Okay, that's different to prevent stuff that will help with, you know, the high risk. Like, do you work with cardiologists or do you not?
We do if they're advanced problems. Absolutely. I mean, I can't wait to get my book out to you guys, because, and each of you have the opportunity, just as you, Joanne and Mike, you know, to come in to the clinic and schedule a free consultation to understand what is it that we can do for you. Or if you've come in and done testing with us, we're happy to go through it so that you understand it. So don't ever feel like, hey, I'm out in the, this is why we do these education sessions, is so that we can be there as a resource to help you understand your numbers, to make it clear for you, and to then show you what other testing we're doing. Because Joanne, you probably remember this, when I started, we were doing barely anything. And now I've got all this extra testing. We've got heart scans. We've got all this advanced blood work that we can do now, and all these advanced other blood works that get into understanding why people end up with cardiovascular disease. This is what we do now. And I mean, I started our clinic in 2007. We're not the same clinic we started like 18 years ago. It's a whole new world out there. And this is where we go a lot more in depth to seeing what's happening.
Oh yeah, no, I'm definitely going to do this heart test first. I really like it, but thank you. Yeah, no, like I said, I will get a hold of you, because I'm going to do this blood work myself, because it runs in my family. So, and with Mike, I will touch base with you on that.
Sounds good. Thanks, Joanne. It's nice. Always nice hearing your voice.
I know. Nice seeing you too. Thank you.
Yeah.
All right.
I thought someone else put their hand up there. Go ahead and there's anyone else? No. I see there's a couple more tests or questions there. I just wanted to comment on this. Well, I guess it was answered here. So
Diamond, I've been answering some of the questions
thank
in
you.
the chat.
Perfect. Yeah.
And
Mediterranean, the
coming.
Mediterranean diet is absolutely a good diet to start on. When you come to the Heart Fit Clinic, it's important to understand micronutrient imbalances. It's important to understand gut inflammation. And so if I were to pick one way to eat, it would be a Mediterranean style diet, but I would try to eliminate obviously sugar as best as possible, so you don't end up, you know, insulin resistant or diabetic. That's a big issue. And then walking, of course, and exercise, those are important things, keeping stress under control. That's what my first book was about, is 5 powerful pillars to prevent and reverse heart disease. And I cover that in that book. And if you don't have a copy, just let us know and we'll get you one. But that's important stuff to be able to understand. How much the blood test costs, I want to say, I think it's around $1,500 to do both of the tests. And I believe we're doing an offer of $1,000 to do the testing on this call. So that'll all be sent out to you by my staff here tomorrow. So they'll make sure that you have this. I think those are the questions you've been answering along the way. So that's great.
Take advantage.
Les, did you have a question there?
$1,000 per us. 1,500.
Okay, I think we're just talking there. It's fine.
Just maybe a follow-up.
Go ahead, Stan.
What's happening with, like, why isn't the regular medical world accepting some of this blood work, blood tests that you guys seem to be offering that seems valuable, and you've been in the business now for 18 years? Are they just difficult to adopt, or is it just too expensive?
You're asking a question that is more political. So I can't answer that for you. when we talk about, so I wrote a white paper, and I'll send this all out to the group. And the white paper talks about the 3 important things when it comes to understanding cardiovascular health. Number 1 is that cholesterol doesn't cause heart disease, and yet we're still stuck in that model of, hey, my cholesterol is okay, or it's good, or I'm taking a statin, so I'm okay. And I think that's good, but understand that cholesterol is important to understand particle sizing. And there are other buckets of cholesterol that are important, as mentioned here on the talk today with Rhonda, lipoprotein A, small particle sizes with HDL and LDL. And good cholesterol can also become atherogenic or plaque-causing if they're the wrong particle sizing. And so also very low density lipoprotein. So there's other particles to be able to look at. And in the US, and maybe Rhonda and Aparna can comment on this, I believe these tests are covered, if I'm not mistaken. Am I right?
They are covered by Medicare and Medicare Advantage,
Yeah.
and they have only been on the market for about 2 years. So, and they've just been on the market or offered by HeartFit in Canada for the last 4 or 5 months, I believe.
Yeah. So, I mean, you can get it covered through Medicare in the US, but in Canada, we can't. And so this is why we do what we do. Like, I mean, this is the stuff that's going on. And again, this is just one of the many things that we do at the HeartFit Clinic. And I just wanted to highlight one of these tests because a lot of people are getting this test. And I want them to understand what the test is involved and what it does.
Yeah, no, appreciate that. Thank you. Good information.
The healthcare system is like a cruise ship trying to do a U-turn. So it's going to take a long time for it to get around, but maybe it does, maybe it doesn't. But we in Canada have a very good reactive system. We don't have a good proactive system.
And if it's any help in the United States, cardiologists get paid for stress test and imaging and stress echo. They don't get paid for lab tests.
No, they
So
don't.
we have a lot of, as Diamond's talking about, doctors that are into prevention, your primary care, your lipidologists, your endocrinologists that take care of diabetics that don't have access to these advanced tests that you wait 6 months to see the cardiologist and then months to get them scheduled. So having a highly accurate, accessible blood test is so important for your clinicians to be able to order it and get results, inside of a couple weeks.
Yeah, we're a little bit behind in the preventative world, and this is why the HeartFit Clinic is here to be of service to you. So, and then more importantly, have the right strategies so that we can help you prevent and reverse heart disease. So that's our big focus. If there are no any questions, I'll just, if you want to unmute yourself, you're more than welcome to. And if you want, you can use the chat if you feel more comfortable, whatever's easier for you. But more important, if you have any other questions, again, you're more than welcome to come into the clinic and discuss them with our staff. We got great staff in all our clinics. So we're in Calgary, Edmonton, Vancouver, Toronto, and London, Ontario. So I'm happy to answer and be of service to you anywhere where we're at. And if there aren't any other questions, this is being recorded, so you'll have a video afterwards. And we look forward to helping you and continue to help you live happier, healthier, and longer. Thank you, Rhonda. Thank you, Parna, and thank you, Provenio, for being on the call today and talking about the tests that you do. Thank you very much.
Thank you, and to everyone's heart health.
Thank you very much.